So for our session today, I just want to start off with just an introduction and give a little bit of context of how we got here. Then we'll talk about the Meaningful Measures Initiative, both what it is, the framework, some of our successes thus far, and hopefully give you a little bit of a glimpse of what's to come. Outline a few resources that we have, and then we'll obviously end with a Q&A. So hopefully there'll be many things that you learn and take away from this session, but just to outline a few, I hope that you're able to recognize some of the challenges with measure development and kind of what led to the Meaningful Measures Initiative being created. I hope you are familiar and become familiar with the framework and are able to see how some of our measures fit with that and apply our measures to the Meaningful Measures framework. And then I hope that you're able to recall some of the successes that we've had in having used the Meaningful Measures framework in some of our CMS quality and reporting programs. But before I start talking about the initiative, I just want to take a step back and just discuss, like I said, a little bit about how we got here. So my daughter just turned 1 in August, and that means I've been going to appointments nonstop for the last 2 years between my primary care, the OBGYN, now the pediatrician. It just feels like every single month I'm going to at least one appointment for one thing or another. And seeing 3 different providers almost simultaneously, it made me realize how much time my primary care physician spent looking at his computer screen. And really kind of paying attention to that relationship and how sometimes that really became an obstacle when I was trying to talk and express my needs, et cetera. So I realized that as a patient, but I also realized that as a CMS staff person as well. And we recognize that, and we really want to work to change that, to be able to give back time to the provider, to have that better relationship so that we can improve outcomes, improve healthcare outcomes overall, because that is precious time and it's important. And so what Patients Over Paperwork does is really prioritize that patient-centeredness and works to really evaluate the regulations that are obstacles to having that relationship and having those healthcare outcomes improved because of that relationship. And so Patients Over Paperwork is just one kind of initiative in our wheel of our strategic priorities that we're using to make sure that we're putting patients first across all of our programs, across Medicaid, Medicare, and the exchanges. And so we're doing this by making sure that we're empowering patients, making sure that they have the resources they need to make the best decisions possible. Meaningful Measures is a part of that, and I'll talk about that. By making sure that we're focusing on results and that we have new flexibilities and new incentives to make sure that patients are getting the right care at the right time in the right place, and everyone has the data and results to be able to make that happen. And then lastly, unleashing innovation. I've seen lots of innovation even in the first few hours of being here, and I realize that, as a government agency with our regulations, that sometimes we put barriers to allowing for innovation, and so we're working to remove those. And so when we think about these 3 kind of principles or 3 ideas in the context of quality, the one thing that comes to mind is interoperability. We can't unleash innovation. We can't focus on results unless the data is talking seamlessly, and that we're sharing data seamlessly. And we can't have the innovative payment models that we need to have and improve our health outcomes and decrease costs, et cetera, without interoperability either. And so we need to advance interoperability in order to advance not only the CMS goals, but a lot of the goals that you've been hearing about today. And without effective, open data sharing, providers aren't going to be able to keep the patients healthy. Without that data and being able to track patient progress and understand quality, insurance companies, whether it's CMS or others, we're not going to be able to tie payment to outcome, and that's really the underpinning of a lot of the CMS quality programs. And so, we recognize that that healthcare system, it can be a bit of a black box. It can be overly complex. It can lack transparency, and it can be really difficult to navigate, even for the most literate most health literate of patients. And so we're working to working to change that and working to give the information back to the patients. But not doing it in a way that's burdensome. You know, when my daughter had her first doctor's appointment, she was 5 days old. I was practically delirious of not sleeping for more than 60 minutes at a stint. But yet it was my responsibility to make sure that I tracked that folder from the very messy hospital room all the way to home and then back, that I transferred that data. And that's not the way that it should be, because if I would have lost that information, it would have led to disconnected care. It would have led to worse health outcomes. It could have led to higher costs, et cetera. But unfortunately, in our system today, that's really the reality. And so we're really working to change that, making sure that patients can take ownership of their data. And I don't mean ownership by driving it around in a car like I did, but really that they have an interoperable healthcare data exchange that does it for them, that providers have accurate and timely information they need to make the healthcare decisions in that moment and not wait a week for the test results to come in or, you know, get transferred through the various systems, et cetera. Because having an interoperable healthcare data exchange is what's going to lead to and enable the coordinated care, the improved health outcomes, and the reduced costs that we need moving forward. Because that's what's going to allow us to not have to repeat the expensive tests, to avoid the adverse drug interactions, et cetera. And really, when we think about it, having interoperability is what putting patients first is all about, and what having patients over paperwork is all about. And so in the beginning stages, when we were thinking about patients over paperwork, and I'm going to talk about meaningful measures in a moment, we really focused on aligning measures, reducing measures, et cetera. And we're still concentrating on that, there's no doubt. But what we're doing moving forward is making sure that we're creating policies that drive a system where doctors and their patients are incentivized to make sound decisions based on patient information in a safe and secure environment. And interoperability, of course, is going to support this in ensuring that there's low burden of data collection and exchange, et cetera. And so, you know, the slides we made, you know, they'll be able to be downloaded later so you can really kind of look at this slide. But here are some of the initiatives along with things like Blue Button 2.0, some of the CMS innovation center models, et cetera, that are working to do this. And so where are we in our journey to improve quality? Well, we look in the last 20 years with the IOM report, we've come a long way. Still need to go further, but we've definitely improved readmission rates. We've definitely improved hospital-acquired conditions, et cetera. But we've also, you know, increased the burden. We've also given patients lots more information, but it's not always the most meaningful information. We have the stars, we have the different compare sites, et cetera, but there are improvements that can be made there. And so we want to make sure that our journey going forward with quality is really putting patients first. And that's where the Meaningful Measures Initiative comes in. So kind of launched almost simultaneously with the Patients Over Paperwork kind of initiative was the Meaningful Measures Initiative. And what that really is to improve patient outcomes, reduce data reporting burden and costs to clinicians and providers, as well as making sure that we're focusing our quality measurement initiatives and making sure that we're all going in the same direction, et cetera. Because we really wanted to use this as an opportunity to take a pause from the fast pace of measure development, to take a pause from all of the measures that we were implementing, et cetera, and really reflect on what was meaningful to patients. And so we have this new approach, of course, that's needed because we had these disparate measures, because of the reporting burden, because we needed to promote alignment, et cetera. And so these ties in, you know, everything I've said so far really ties in perfectly with CMS's 4 strategic goals. I won't go over these in detail, but, you know, really the 4 strategic goals of flexibility, state flexibility, and local leadership, improving our CMS customer experience for everyone, making sure that innovation, again, is not a burden. I'm sorry, that innovation is not hindered by regulation, et cetera. And then, of course, at the very top and most important, empowering patients and doctors to make decisions. So as we begin to look at our approach to measures and alignment, we need to come up with some objectives on how we're going to really standardize the evaluation of our measures as we looked at them. And so that's where we came up with these very concrete 8 concepts to make sure that everyone was on the same page and really identify those top priorities and focus everyone's efforts again in the same direction and lend specificity to our measure sets. And so really focusing on things like making sure that we're addressing high impact areas, trying to get rid of topped out measures, making sure that we're measuring outcome based where possible and trying to get rid of some of those lower level process and structure measures where possible. We are a regulatory agency, and so we do need to follow statute, et cetera, and fulfill those requirements, but we can still do that in a way where we're still aligning across not only our CMS programs, but also our payers as well. And so it's our hope and belief that by naming our focus and kind of working on the most meaningful measures possible, that we're going to decrease the burden of the reporting burden, the data collection burden, et cetera, on our providers, and that will increase the time that's being spent in that room and having my doctor look up from the screen and really have a good communication with me and really being able to talk to me and I feel heard, they feel heard, and have a good solid conversation. And with that, we will be increasing quality and increasing health outcomes. And so CMS, I don't need to say, is a vast organization with a lot of different levers that we can pull. And so here are just a couple that I think show the immense reach that we have and the different areas where we can make some effect. So, things like making sure that patients and caregivers are a part of our measure development and public reporting efforts, making sure they're a part of coming up with those, making sure that patients and caregivers have access to data, making sure that the infrastructure supports the development of health IT-enabled measures, et cetera. And all of these levers are really key steps that CMS can take to really try and impact health quality, and meaningful measures supports these through the objectives that I went over, as well as the framework that I'm about to show you. And so the initiative is more than just objectives and levers. We have a really concrete framework. It's a really concrete tool that I'm going to kind of click through here. And basically what you see first, hopefully you see first, at the center is the patient, of course, at the center of everything we do. We have the patient and the provider and the depiction of that relationship along with our CMS goals. Then kind of in the bold text then around the circle we have our 6 cross-cutting criteria. And these are kind of criteria that almost every measure should meet. So things like reducing burden, eliminating disparities, tracking to measurable outcomes and impact, achieving cost savings, et cetera. Then we have our healthcare priorities, which is what you see in the bold, like promote effective prevention and treatment of chronic disease, work with communities to promote best practices, make care affordable, make care safer, strengthen person and family engagement, et cetera. And so the idea is that, say, for the strengthen person and family engagement in their care, making sure that we have measures under each of these categories. So so we have the healthcare priority, which is in the blue text, the strengthen person and family engagement, and then underneath we have these meaningful measure areas. And that's where we want to make sure we're creating measures in each of these areas to make sure we're achieving that goal. So making sure that we have measures that track and measure to, care is personalized and aligned with patient goals. Do we have measures that demonstrate that providers are doing that? End of life care according to preferences. Do we have measures that do that? These 19 meaningful measure areas that fall under these 6 big categories are what really illustrate kind of our 19 quality priorities. And so with that, we kind of have our first poll question. Just kind of want to get just an idea of just kind of your first glance or what's your first kind of gut reaction to this. So on a scale from 1 to 10, and don't be shy, you can say disagree. On a scale of 1 to 10, the Meaningful Measures Framework resonates with my work and the work of my organization. strongly agree to strongly disagree or not sure, not applicable. So from first kind of gut reaction, does this speak to you? Does this initiative, does this framework speak to you?
Okay, go ahead and take a second. And if we can show the results on the screen now, it looks like the majority of the people in the room are choosing option number 2. They somewhat agree.
Okay, awesome. I am happy to hear that. And please, feel free to provide additional comments or questions with that. Especially, I can't see the screen, but especially if you said it didn't resonate with you, I'd love to hear why or what pieces. So I do, it was a kind of a quick, there we go. That was kind of a, sorry, 1 second. Okay. That was kind of a quick overview of the framework. So I want to do a little bit of a deep dive and look at promote effective care and communication, effective communication and coordination of care, which is the top healthcare priority. So under that, we have 3 meaningful measure areas. So we have medication management, and we can think about that for a second. So medication management, it's critical because we want to make sure that we're avoiding medication errors, drug interactions, negative side effects, et cetera. And we know from data and statistics that in the US, adverse drug events are estimated to cost $3.5 billion and result in the death of approximately 7,000 people annually. And so it's imperative that we improve patient health outcomes in this area. And so if you look, we have examples. They aren't all of them by any means, but we have a couple of examples of actual quality measures actively in our programs that fit underneath of this. So use of high-risk medication in the elderly, medication reconciliation post-discharge, et cetera. Same thing with admissions and readmissions. We've heard a lot about that this morning, about what an issue that is. And while we've made improvements, we need to continue to make improvements. And so there are a couple of examples of measures actively in our programs that fit that. And then lastly, transfer of health information and interoperability. I'll give you a quick look at another one as well. So again, the healthcare priority is promote effective prevention and treatment of chronic disease. And then we have these 5 meaningful measure area categories underneath of these. So preventative care, management of chronic conditions, prevention, treatment, and management of mental health, prevention and treatment of opioid and substance use disorders, and finally, risk-adjusted mortality. Again, with several examples of measures, along with some of their corresponding programs that they're in. And so by having the meaningful measures objectives as a guide, really employing the key levers that I talked about earlier, and then using the framework as a compass for our measure removal, our measure evaluation, when we are employing and looking to create new measures, et cetera, we're really hoping that we are aligning with and working to align existing quality measure programs, as well as across payers. We have some initiatives that work where we bring payers together and try and develop core sets. We hope that we're allowing clinicians and providers, again, to really focus on the patient and improve quality of care. We're hoping that we are capturing what's most impactful and what's most meaningful both to patients and providers. And like I said, really using this as a guide for rulemaking, our impact assessments, et cetera. So it's been we are about a month shy of 2 years of having the Meaningful Measures Initiative. And so what do we have to show for it? What are some of the things that we've been doing and some of the progress we feel like we've been making? One of the things that we did, which I thought others saw as well, was really innovative that we hadn't ever done before, was issue cooperative agreements. So we awarded $26.6 million in funds to specialty societies, patient advocacy groups, researchers, et cetera. You see the list of 7 here. But needless to say, not the traditional measure developers that we go through. We were trying to get outside of that box because we really felt that groups like these have a really unique position to establish some more appropriate measures for clinical specialties that are underrepresented in the current measure sets of the QPP under the QPP. And that they are in a unique position to really create measures with the goal of improving patient care and really focusing on outcomes. And some of these cooperative agreements are converting existing registry-based measures and converting them into ECQMs, or electronic clinical quality measures, which ultimately brings in one of our goals, which is reducing burden. We also have our measures under consideration list. This gets a little bit into the weeds of how we implement our measures, but at a high level, the measures under consideration list is where we do a call for measures through our pre-rulemaking process, and we say, hey, public, what are some of the measures that you would like to see in our program? Let's have a sneak peek. Let's, you suggest them to us. So we do that, and over the last couple of years, we've had a decrease in both the number of measures that we've kind of accepted onto the list, as well as decrease in the number of submissions that we've received. And we think that that's a good thing. We think that that means that that's us communicating our needs, that that's us communicating exactly what we're looking for, our various objectives, et cetera, that I've outlined, that we're giving people a clear picture of this is where we're going. We're creating a roadmap for them. And so in 2017, we had 184 submissions. Again, we were able, using the Meaningful Measures framework and our objectives, we were able to narrow that down to only 32. So that's an 83% reduction. And then in 2018, we narrowed the 67 submitted down to 39. The other thing that we did under the Meaningful Measures framework, and this is not my program, so I can't answer specific questions about this example per se, but I just wanted to highlight this as an example of the process that we went through. So with patients over paperwork, remember we said we were decreasing regulatory burden, et cetera. And part of that is making our measure sets smaller and having less measures and making sure that the measures in our program are the most meaningful, that they are the most valuable, et cetera. And so what we did was we used the Meaningful Measures objectives and our framework to evaluate every single measure in each of our programs across CMS. The inpatient psychiatric facilities, ambulatory surgery, cancer hospitals, et cetera, all of them. And we ranked each measure red, yellow, green, red for removal, yellow for, under debate, and then green to retain. And we proposed that, we proposed removals then in the subsequent year. And through that process, we were able, in around the 2018 timeframe, we were able to eliminate 79 measures from our programs, and through the systematic approach of evaluation. That's a projected savings of $128 million and an anticipated reduction of 3.3 million burden hours because of those 79 measures. And then here's a further example. Again, not going to go through this in too much detail, but this is an example of the fiscal year 2019, one of our rules, where we eliminated 19 measures. We removed 8 of the 16 clinical quality measures, and really just decreased the amount of burden that we had within that rule. But I do want to stress, though, and I know, the initial thought with patients and their paperwork as well as Meaningful Measures was it was all about elimination, all about removal. And that's definitely a very big part of that, because we hear our stakeholders saying that there are too many measures, there are too many disparate measures. And so we definitely recognize that, and that was definitely the first push. But we're also using Meaningful Measures to guide our future measure development as well. And really say, where should we be going? What measures should we be developing? And so in that same rule where we eliminated 19 measures, we also proposed and finalized the adoption for 2 opioid-related measures that were ECQM. So we're kind of working at it in both directions. So like I said, it's been about 2 years We're constantly kind of reevaluating and updating, et cetera, our initiatives and our frameworks and making sure that we're staying relevant to the work and letting it kind of grow organically, et cetera. So where are we going? What are the next kind of 2 years going to look like here? Well, like I said, meaningful measures is about removal, but it's also about development. And one of the frustrations that I hear from providers and stakeholders is that it's not just about the reporting, but it's about the type of reporting. It's about, they don't mind reporting. They don't mind entering the data into their EHR to get collected or et cetera, but it's really about reporting on what they feel doesn't matter. And so part of it is trying to get to measures that matter. Because when we look at patient-reported outcome measures, everyone loves patient-reported outcome measures, and we want more. But if we really look at it, they can be very burdensome. They can be very resource-intensive, because a lot of times it sometimes means, doing surveys and calling up patients and seeing how they're doing, et cetera. And so, but we feel like it's worth it because it's coming directly from the patient. And so we do have some development priorities. Again, these are still kind of under, we're still refining some of this, but development priorities like PROs or patient-reported outcomes, definitely working on ECQMs. Of course, opioids is on the list, but we're also looking at nursing home infections and different safety measures. Maternal morbidity and mortality definitely has been a concern, and then also sepsis. And then we also need to start looking at advancing our electronic sources, developing more APIs for quality measure data submission. APIs can really help practices improve the usability of their electronic health records and their EHRs with the assistance of third-party software to try and consolidate that health information into one place. I've seen lots of very cool dashboards while I've been here, and we definitely want to be a part of that. We're also exploring fire standards and trying to eliminate the need to learn and maintain multiple standards. Looking at interoperable electronic registries and incentivizing their use, harmonizing measures across registries, timely and actionable feedback to providers and making sure that that's getting to be a quicker and faster pace and not a 1, 2, or more delay like we have been seeing. And then also working across CMS to use artificial intelligence and try and predict outcomes. Some of my colleagues in CMMI are working on some of that. So again, we're still trying to figure this out, and of course I would love any feedback that you have. And you can feel free to, of course, give it now during this presentation, or the Meaningful Measures QA email box is a great resource if you have thoughts afterwards as well. But our priorities kind of going forward can at a very high level be summarized in the following. Modernize value-based programs. We want to make sure that, again, we're aligning, we're reducing burden, we're focusing on the measures that need our top priority and advancing interoperability. We want to make sure that we're continuing to refine our priorities and really focus on the key measure gaps and trying to find those and fill those with things like I mentioned before, like maternal mortality, morbidity, opioids, nursing home infections, et cetera. That we are focusing on domains of population health, patient-reported outcomes and cost, and then also advancing electronic infrastructure. So really increasing the speed of reporting to support more timely feedback, both to the provider, but also increase the feedback for our public reporting so that our patients and caregivers can make more informed decisions, et cetera. And then lastly, making sure that we're improving patients, or that we're engaging and improving the ease that patients can engage with us through transparency, not only with the data, but also kind of the process of measure development and also the public reporting, like I mentioned before. And so with this, we come to our second poll question. I can kind of take a guess at what this might be, but who knows, I might be surprised. So which of these initiatives, I kind of just ran through, which of these initiatives is most important to you? modernize value-based programs, continue to refine priorities and focus on key measure gaps, focus on domains of population health, patient-reported outcomes and cost, advance electronic infrastructure, or improve patient or consumer engagement through increased transparency and public reporting.
Okay, again, this is session number 8, question number 2. Go ahead and take a couple more seconds to get your votes in. Kimberly, right now it's looking like advance electronic infrastructures coming in first with 23%.
No,
There's
I
a
am
close tie.
surprised. Here we go.
The second one coming in close is focus on domains of population health, patient-reported outcomes, and cost. It's really close.
Awesome.
Those two.
All right, well, I must say you guys did surprise me. I thought it was going to be overwhelmingly advanced electronic infrastructure, so it's exciting to see that there's a little bit more of a curve there than I anticipated. All right, so I do want to take the last couple minutes before we go into Q&A to cover some resources. First, we have our Meaningful Measures website. Has a lot of great information. There are fact sheets. Each of the 19 meaningful measure areas that I kind of mentioned, they're defined there, so you can kind of see what do we mean when we say medication management, what do we mean when we say equity of care, etc. So a lot of great information on there, as well as videos, etc. So definitely encourage you to check this out. I might be a little biased towards this next one, but this is the Measures Management System website. And basically, at a very high level, the Measures Management System is really a system of tools and resources, et cetera, that guide the measure development across the entire agency. So we have things like the blueprint, which is a 400-page, it's a little overwhelming, but it's a 400-page document that describes how you develop a measure from start to finish in very great detail. Though you can read the first 30 pages, it has a nice little overview, and then the rest of it reads like an encyclopedia. So you could go straight to an independent chapter and read up on risk adjustment, et cetera. We also have things like our Get Involved tab on the website, which outlines a lot of our technical expert panel opportunities that we have, our public comment periods, etc. So I encourage you to check that out, as well as you can sign up for a monthly newsletter that will outline some of those opportunities, and try and culminate some of the quality measures information and resources, et cetera, across the agency. And then we also have an extensive list of collection of resources. So if you need a 101 on ECQMs or risk adjustment, et cetera, this is really your go-to resource. Then we also have our CMS Measures Inventory tool, which is a repository for all of our quality measures across CMS. And it captures the entire life cycle. So if you pull up the page, and I might fix this because I heard it a little earlier today, but if you pull up the page, you see over 2,000 measures. We do not have 2,000 measures actively in our program. This captures ones that are under development, ones that we considered but decided not to go with, ones that were removed, etc. We have about 800 that are actively in use, but it captures that entire life cycle so you can see what happens. And so again, this might seem a little of an odd question, but I want to get to our third and last polling question. Just because, again, I'm curious. We want to make sure that we're creating tools and things and resources and websites, et cetera, that resonate with you. So be honest. You won't hurt my feelings, I promise. How likely are you to visit one of the previously listed resources? Very likely, likely, unlikely, very unlikely, or you're already aware and you've already been to some of these places.
Okay, with the results coming in,
like
it
that.
looks like a really eager audience. 46% are saying they're likely to go to those resources.
Awesome. Well, that's very exciting. Thank you. All right, so just before we get to, I was trying to, I think it's up to you. Yep, there you go. Nope. There you go. Before we get to and open it up for Q&A, just wanted to quickly go over the key learning and recommendations. So hopefully you got lots from this session. I hope that you did. But at minimum, I hope you realize that we are working to try and support our measure sets, make them better coordinated, make them more patient-centered, and really have a more focused so that we're going in the same direction. That we're really committed towards alignment across programs and across payers, that we're working to improve our electronic infrastructure, and that really our primary goal is about the patient and trying to make sure that we are removing obstacles removing obstacles that get in the way of the time that clinicians have to spend with their patients. And here's my contact information as well as the box for the meaningful measures Q&A. They still come to me as well, so either one is fine. And please let me know if you have any questions. I think we're going to go with the top 3 first.
Awesome. One more time. Okay, here we go. All right, I'm going to come up here with you. So
Okay, awesome.
we have a lot of great questions.
Okay.
And we're going to begin with the ones that are submitted that have the most audience votes.
Mm-hmm.
And the first one with the highest number of votes is, what can we do to what can we start doing today to reduce paperwork for providers?
That is a great question. So I think, a lot of it, what we're focusing on with meaningful measures is, is obviously our quality measures and trying to have less measures. So obviously it's definitely part of it. But as far as today, I think what you can do is give us feedback to try and make sure that we're making the changes in the correct, that we're making the changes that you feel like will be most impactful, and that we're going in the right direction. I think, and I'm forgetting the exact example, but there was something little that we did. It was about, I think it was like if you're a doctor and you have someone, like a resident or someone working underneath of you, like that, and they entered information, like you would essentially have to go back and double enter that information, enter it a second time. You wouldn't just be able to kind of click check, okay, that looks good, and kind of send it forward. And that was something that we heard from providers, and we heard from people that was a huge hindrance and just cost time and time and time. And so we removed that requirement. So, as far as what can you do today, I think it's to get involved. I think it's to visit our website, to visit the measures management website and see what technical expert panels you can get involved in, see what measures and what programs have an open public comment and make those comments, et cetera. And, and sometimes it's also about going through different specialty societies and writing one as an organization or writing one as an individual as well. So I think the top is really getting involved.
Thank you. So another one has jumped to the top.
Okay.
Do you believe structured clinical data is sufficient to capture provider performance? Or will there be a need to leverage narrative data, clinical notes, to fully gauge quality performance?
So I think it's about creating a balance, right? I mean, right now, we need the structured data in order to easily track in order to easily track the information and very easily pull the outcomes and the patient information out so we can, do a lot of the innovative things that we're talking about at this conference. However, not everything can be structured. Not everything can fit into a 5-answer into a 5-answer question or into a 5 or 10-answer kind of data element. And so I think that there's a balance there that we're trying to reach, and I think kind of trying to open and trying to look at some of the more innovative approaches that we're hearing from and innovative things that people are doing with their EHRs, like all of these systems that I've been hearing about, making sure that we're not hindering that innovation moving forward and making sure that making sure that those things are available to folks and we're not an obstacle in that relationship.
Okay, the third one we have is CMS working on aligning measure specifications. MIPs follows ECQM shared savings follows web interface, and Medicaid and commercial payers are following HEDIS. Currently, we have a single measure, for example, A1C poor control, that can be defined in 3 ways.
Yeah, so that is, so I can't speak to that directly, except that to acknowledge that that definitely is an issue. We recognize that a lot of times, like, we will put out the specifications, but it will get interpreted by every single EHR in a different way. And that's definitely an issue and a concern, and we're working on that.
All right, with social determinants of health affecting measures and patient outcomes so much, access to transportation, homelessness, et cetera, what incentive do health center and community health centers have for addressing these issues when measures don't specifically address social determinants? Will there be measures which focus on social determinants of health?
That's a great question. And some of our measures are risk adjusted. That's something that we're continually exploring. There's open work being done with the National Quality Forum to work on some of those, to work on social risk factors and social determinants of health, and see how we can work that into measurement, and what are some of the various models, et cetera, that can be employed to improve that. I think there are a couple ways to answer that question. I think a lot of our CMMI, our Center for Medicare and Medicaid Innovation, a lot of our CMMI models take that into account. I've seen several programs that will fund and kind of pay for and support things like case management, et cetera, to try and give more of a fuller, rounder package of support to help improve health outcomes. And then, I think we are moving into this more population health mode, and trying to get away, obviously get away from fee for service, but really going into the pop health arena, which will force payers and providers to take that into account. And with our CMMI models, trying to figure it out, we're trying to support them in that journey going forward.
Okay, are there measures specific for working with people with disabilities or standard definitions for disability status that CMS would recommend providers use?
I do not know the answer to that question. But whoever answered, if you follow up with me either in email or I can get your information after we leave, I'd be happy to look that up. You can also try the CMS measures inventory tool that I demonstrated before, or showed a slide of. That is a great resource. It has lots of filtering and search capabilities, and you might be able to find your answer there as well.
All right, the votes are jumping around, so hold on just a second.
Yep.
Are there specific regions of the country that are having problems with specific measures?
I don't know. I will say, and we recognize that it is more difficult for rural communities, oftentimes, smaller practices, et cetera, to report on some of these measures. And one of the cross-cutting criteria was to try and help and improve that, and work with rural communities and rural health initiatives. I would say, the best resource to answer that question might be our impact assessment. I don't know if it does it by geography, but I know it kind of looks at health outcomes in urban versus non-urban settings, and really gets at some of the rural issues. But the impact assessment is a 3-year annual report that we do that really takes a 50,000-foot level and says, hey, we have all of these quality measures, we have all these quality reporting programs, have we moved the needle in any of these areas? And so it really takes that 50,000-foot level and looks at that. And I know that geography, I'm not 100% sure about region, but I know that geography and population density, et cetera, is a factor in that report. It's very interesting.
So one of our big barriers is the inability to promptly get hospital discharge data. Providers have 30 days to sign reports, and hospitals will not give PCP patient discharge report until signed. Would CMS be in a position to influence hospitals to be more flexible, or hospitalists be compelled to sign notes in shorter time frame?
I'm also, so I can't really speak to that and make a commitment. But I think it's a great suggestion, and definitely one that I will take back.
Within this framework, what mental health measures are thought to be of highest value in monitoring outcomes?
Sure. So I'm actually going to click. So I'm assuming you're thinking, I just wanted to look at the framework real quick. There we go. So I'm assuming, so here's the framework with all, the 6 quality measure priorities and the 19 meaningful measures kind of all consolidated on one screen. We do have a couple of areas that address and kind of speak directly to mental health. And if you go into CMIT, into the CMS Measures Inventory tool, one of the filters that you can actually, or one of the areas that you can actually filter by is by meaningful measure area. So you could click the prevention, treatment, and management of mental health priority or meaningful measure area, and it will show you all of the measures that we've categorized under that area that are actively implemented in our programs.
Okay, it looks like we have time for maybe 2 more questions. With it, let's see, do you support a national patient identifier? And would there be a reason for that?
I am also not going to comment and speak on behalf of all of CMS for that. There's some hefty questions, guys. All right, yeah. I mean, I can't speak for everyone on that, so I'm gonna defer that question.
Okay. Has any thought been given to requiring electronic medical record vendors to incorporate and keep up with the CMS requirements?
Can you ask that one more time?
Has any thought been given to requiring EMR vendors to incorporate and keep up with the CMS requirements?
So with ECQMs, it should be, like they should be. So I'm a little, so I'm sorry? In a more Gotcha. Okay. So more than every 6 months to a year? Okay. All right. I will take that feedback back. I mean, because it's my understanding that we put those out, and update those specs, at least on an annual basis. But what you're asking for is more frequent, more timely. So, okay. Oh, thank you. All right.
How do you adjust the value model to account for the differences in metrics?
I am not sure about that question. Does someone want to kind of
Does
elaborate?
somebody want to elaborate on that question?
A little bit? No one's owned up to it? All right.
It was, how do you adjust the value model to account for the differences in metrics?
All right. Well, feel free to email me. As is obvious by my answer in a couple of these questions, I am not an expert, especially in ECQMs and EHRs and FHIR and things like that. But by all means, if you email me, I promise I will personally put you in touch with the person that is, or guide you, find a website and guide you to that information that has the latest kind of statements on what CMS has made on that various topics. So apologize if I didn't give an adequate answer to all of those, but like I said, follow up with me, email me, and I will make sure you get that information.
Okay, maybe one more question. Let's see if we can fit it in. Policy decisions seem to be overly tied to finances. The EHR pulled through many elements in the documentation forward for subsequent visits, leading to higher utilization of level 4 or 5 visits. The pushback will be going to 2 new patients and recheck visit levels of care. As a specialist, I will need to see a patient 3 or 4 times to obtain the information I need for care provision. There will be no cost savings. I can't accomplish in 20 minutes what 60 minutes compensated time provided.
So I don't know if I heard
Can somebody elaborate on that one?
it seemed like a little bit more of a comment,
Yeah.
which I would definitely
Was there
take back. But
Additional question there?
Sure. Yeah. Yeah, I mean, I think, we have a lot of different priorities and a lot of different levers that we're trying to balance, and so I think it's trying to find that balance. I can say, with at least with meaningful measures, cost doesn't factor into that. But as you saw on the wheel with the various initiatives, we can't ignore costs. either. So there's a balancing act there. All right.
Okay, 1 minute. Let's
Okay.
see. So just quickly, the difference between meaningful measures and patient over paperwork initiatives.
Sure. So the patient over paperwork initiative is much larger. It's much broader. That encompasses a lot of our regulatory burden reduction initiatives. Things like eliminating removing some of the barriers, like I said, that removing some of the barriers to try and unleash some of the innovative ideas that the private sector is coming up with. That would be considered a part of patients over paperwork. And we're trying to, partner with clinicians and providers and suppliers, et cetera, to try and accomplish that. But patients over paperwork is really about trying to remove the red tape, remove the obstacles, remove the burden, et cetera. And meaningful measures is really trying to focus us all in one direction when it comes to measures. And so meaningful measures is really just kind of a small piece of the patients over paperwork initiative of that pie.